The knowledge of the muscles innervated by different branches of the brachial plexus and the various actions of these muscles and the areas of anesthesia makes it possible for physicians to determine the localization of a given lesion. In this video, we will be looking at the lesions and the diagnosis of the brachial plexus injuries. There are so many causes of the brachial plexus injuries, and they include labor and delivery. Also, fatal accidents can also contribute to brachial plexus injury. Brachial plexus injury at birth is likely caused by a stretch or tear of the child's brachial plexus. The abducted arm of the infant can get pinned against the child's head. This injury results in incomplete sensory or motor function of the injured nerve. Traumatic brachial plexus injuries may occur due to motor vehicle accidents, bike accidents, or sports. Nerve injuries vary in severity from a mild stretch to the nerve root tearing away from the spinal cord. The following are the various degrees of nerve injuries. They include avulsion, rupture, neuroma, and neuralgia. In avulsion, the nerve is torn away from its attachment at the spinal cord. It is the most severe type of nerve injury. Rupture has to do with a torn nerve, although the nerve is not torn at the spinal cord attachment. As for neuroma, it is simply a scar tissue which has grown around the injury site, subjecting the injured nerve under pressure and preventing the nerve from sending signals to the muscles. In neuralgia, the nerve has been stretched and damaged but not torn. Diagnoses related to the brachial plexus injuries include L palsy, Klumpke palsy, thoracic outlet syndrome, Brunner syndrome, and personage Turner syndrome. L palsy involves the upper root nerves of C5 and C6. The patient often presents with the arm extended and the wrist fully flexed. This arm is commonly called the waiter's tip. An individual presented with this condition loses the ability to perform the following motor functions, such as abduction, flexion, and rotation at the shoulder. The affected nerves are the axillary, suprascapular nerve, upper and lower subscapular nerve. Also, there is a weak shoulder extension, weak elbow flexion, and supination of the radioulnar joint. The affected nerves also include musculocutaneous and radial nerves. The patient is also susceptible to shoulder dislocation as a result of loss of rotator cuff muscles. The sensory deficits in L palsy are to the posterior and lateral aspect of the arm due to axillary nerve, the radial side of the forearm due to musculocutaneous nerve, the thumb and the first finger due to the superficial branch of the radial nerve, and the digital branches of the median nerve. Klumpke palsy is a condition that involves the lower root of the nerves of C8 and T1. It is a condition caused by a rare injury of the lower brachial plexus, usually following breech delivery. Some motor deficits associated with this condition are opposite thumb due to the terminal branch of the median nerve, loss of adduction of the thumb due to the ulnar nerve, loss of abduction and adduction of the metacarpophalangeal joints, flexion at the metacarpophalangeal and extension at the interphalangeal joint due to deep branch of ulnar and median nerve, flexion of the proximal interphalangeal joint and the distal interphalangeal joint due to ulnar and median nerve. The sensory deficit that is associated with Klumpke palsy is to the ulnar side of the forearm, hand, and the ulnar half digits. The affected nerves are the ulnar nerve and medial antebrachial cutaneous nerve. The thoracic outlet syndrome is caused by the compression of the neurovascular structures in the cervicoaxillary region. This condition may be congenital or acquired. The bony causes of this condition include clavicle fracture, long transverse process of the 7th cervical vertebra, cervical rib, and the first rib fracture. Soft tissue causes include congenital bands, poor posture, mass lesion, cervical strain, hypertrophy, and injury of the anterior and middle scalene muscles or the pectoralis minor muscle. Brunner syndrome is a condition that is believed to be related to the brachial plexus stretch or the nerve root compression. It generally involves the upper trunk of the brachial plexus, particularly C5 to C6. Brunner syndrome is usually as a result of traction injury with axial distraction or downward force on the shoulder combined with lateral bend of the neck away from the shoulder. Brachial plexus stretch injuries are commonly seen in young athletes, with neck pain being less common. The nerve root compression is found in older athletes, and it is generally associated with cervical disc diseases or cervical stenosis. Neck pain is more common in older athletes. Parsonage Turner syndrome, also known as brachial neuritis, is a condition that is generally associated with a viral prodrome, immunization, and significant pain. Acute excruciating unilateral shoulder pain is present, followed by a flaccid paralysis of the shoulder and parascapular muscles several days later. The Parsonage Turner syndrome varies greatly in manifestation and nerve involvement. Due to the extreme pain involved, patients usually present acutely. Often, the affected arm is supported by the uninvolved arm, and it is held in adduction and internal rotation. The patient may have atrophy of the affected muscles. Pain may occur with palpation and active and passive range of motion. Reflexes may be reduced or absent depending on the nerves involved. Sensory loss is usually not prominent, although it may be detectable. Parsonage Turner syndrome may cause scapular winging. Please don't forget to subscribe and share. See you in the next video.